Okay, think of your bone marrow like the engine room of your blood, right?
Right.
Always busy making red cells for oxygen, white cells fighting germs.
And the platelets, yeah, to stop bleeding.
Exactly.
Yeah,
Now, what if that engine just sputters, can't keep up? That's really what we're getting into today. Aplastic anemia.
precisely. So in this deep dive, we're tackling aplastic anemia. It's a rare condition, but serious. The bone marrow just doesn't make enough of those crucial blood cells.
Which leads to that term, pancytopenia.
That's the one, a shortage right across the board, low reds, low whites, low platelets.
Okay, and our mission today really is to unpack all of this, give you a clear, concise overview, something really high yield for revision. We'll hit everything from the definition right through to complications.
Sounds good. And we should mention there are different types, aren't there?
Right, yeah, inherited and acquired.
Exactly. Inherited means it runs in families, maybe a genetic thing. Acquired means it develops later. And actually, the acquired form is more common. Often we don't even know the exact trigger. We call that idiopathic.
Idiopathic.
Yeah.
Okay, so let's nail down the definition a bit more formally. Aplastic anemia. It's the bone marrow failing, leading to pancytopenia.
Correct. And you mentioned rarity. It really is quite uncommon.
How rare are we talking?
Well, in the UK, maybe 2 or 3 cases per million people each year. So yeah, pretty rare.
Wow. And for diagnosing it, there are specific numbers doctors look for.
Yes,
Huh.
definite criteria. Usually it involves looking at the blood counts. We're talking hemoglobin below 100 grams per liter, platelets under 50 times 10 to the 9 per liter, and neutrophils less than 1.5 times 10 to the 9 per liter.
And you need.
You typically need at least 2 of those 3 to be below the threshold. Think of it like needing a couple of warning lights on the dashboard before you make the call.
Got it. So significant drops, not just minor dips. And you mentioned severity levels earlier.
Especially for the acquired type, we classify it non-severe, severe, and very severe.
Okay, what's the difference?
It comes down to how empty the bone marrow is, the cellularity, and how low the counts are. Severe means the marrow cellularity is below 25%, or maybe 25-50%, but with fewer than 30% being actual blood-forming cells, plus hitting those low-count criteria.
And very severe.
Very severe is similar, but the neutrophils are critically low, like below 0.2 times 10 to the 9 per liter. It's really important for guiding treatment, Gives an idea of prognosis, too.
Right. Makes sense. Different levels need different approaches, so we know what it is.
Yeah.
Now, the big question, why does it happen? What are the triggers, the culprits?
Well, as we said, it splits into acquired and inherited. Acquired is more frequent. A big one here is autoimmunity.
The body attacking itself.
Exactly. The immune system mistakenly targets and damages the bone marrow stem cells. Then there are infections. Certain viruses seem to be able to trigger it. Hepatitis, EBV, HIV, even parvovirus B19.
Viruses acting like saboteurs in the factory.
Kind of, yeah. It's like they mess up the signals, confuse the immune system. Another factor is toxin exposure.
Like chemicals.
Yeah, things like radiation, benzene. You find that in some industrial settings, other chemicals too. And medications.
Which ones?
Some specific drugs have been linked. Classic examples are things like chloramphenicol, an antibiotic, or sulfonamides. It's not common, but it happens.
Okay. What else?
Sometimes after a transplant, you can get something called transfusional graft versus host disease that can damage the marrow. And surprisingly, perhaps, pregnancy.
Pregnancy. Really? How?
It's rare, and the mechanism isn't perfectly understood, but the idea is that the big immune system shifts during pregnancy might just occasionally go wrong and affect the bone marrow.
Interesting. And the inherited side.
The main example there is Fanconi anemia. That's a genetic disorder. Specific mutations lead straight to bone marrow failure over time. But even beyond named syndromes, some people just have a genetic makeup that maybe makes their marrow regeneration a bit less robust.
So genetics can play a role, even if it's not a specific inherited disease.
Right. But bottom line, whatever the cause, the fundamental problem is damage to those critical hematopoietic stem cells in the bone marrow.
The master cells. So what puts someone more at risk of this damage happening? What are the key risk factors?
Well, some overlap with the causes, obviously. Exposure to toxins is a big one, benzene, pesticides, that sort of thing.
Right.
Certain medications, especially things like chemotherapy drugs, are known risks. Radiation therapy, too.
Makes sense. They target dividing cells.
Exactly. Those viral infections we mentioned, Hep, EBV, they're risk factors as well as potential triggers. And having an existing autoimmune disorder seems to increase the risk slightly.
Because the immune system is already maybe a bit trigger happy.
That's the thinking, yeah. It's already prone to making mistakes.
Are there other conditions often seen alongside aplastic anemia?
Yes, there's a known association. We see a higher rate of myelodysplastic syndrome MDS occurring with it or sometimes developing from it, and also paroxysmal nocturnal hemoglobinuria, PNH.
PNH, right. That's one where red cells break down.
That's it. The connection isn't fully mapped out whether it's shared causes or one leading to another, but the link is definitely there.
Okay, so we got the what, the why, the who.
Yeah.
Let's talk about the how. How does it actually disrupt the body? The pathophysiology.
Well, keeping it simple, the core issue is the bone marrow failing to produce enough cells because those stem cells are damaged or just aren't there in sufficient numbers.
Right.
So whatever caused the damage, the result is fewer precursor cells. That means fewer red blood cells causing anemia, fewer white blood cells, so higher infection risk, and fewer platelets leading to bleeding issues.
It's a production line breakdown.
Exactly. The factory just isn't meeting demand.
Okay, so if someone comes in with these low counts, it's not automatically aplastic anemia. What else could be going on? What's on that differential diagnosis list?
Oh, that's a really critical step because other things can look similar. Myelodysplastic syndromes, MDS, are high on the list. They also involve faulty blood cell production.
Okay.
PNH needs specific testing to rule it out. Some types of leukemia can present with low counts initially, especially hypocellular forms.
Hypocellular meaning low cell count in the marrow.
Right. So hypocellular MDS, hypocellular acute myeloid leukemia, even hypocellular AL. Also, things causing hypersplenism, where the spleen is overactive and destroying cells.
So the spleen's chewing up the cells.
Potentially, yes. We also think about rarer things like hairy cell, leukemia, lymphoma, if it's infiltrated the marrow.
That's a lot of serious conditions. Any non-cancer possibilities?
Definitely. Severe infections, things like mycobacterial infections, TB, for example, can sometimes suppress the marrow. Very severe nutritional deficiencies, anorexia, prolonged starvation can impact counts.
Wow.
And other things too, myeloma, even autoimmune diseases like lupus can sometimes present with overlapping features. So you see, you really need thorough investigation.
Absolutely. Now, epidemiology, we know it's rare, about 2-3 per million in the UK. Any other patterns? Age, geography.
Yeah, it's interesting. The incidence is actually higher in East Asia for reasons not totally clear. Age-wise, there are two main peaks.
Oh.
One in younger people, say 10 to 25 years old, and then another peak in older adults, over 60.
Huh. Any reason for that?
It's not entirely certain. Maybe different triggers are more common at different ages. And there's that genetic hint we mentioned. Certain immune system markers, HLA types like HLA-DR2, seem to slightly predispose people to the acquired form.
So even in the acquired type, your genes might make you a bit more susceptible.
Seems that way, yes. Makes the immune system perhaps more likely to react badly.
Okay. Now let's move to what someone might actually notice. What are the signs and symptoms, the clinical features?
Right. This usually reflects the shortages. So with low red cells anemia, you get fatigue, just feeling really weak, looking pale, maybe shortness of breath when you exert yourself.
Makes sense. Lack of oxygen delivery.
Exactly. Low white cells, especially neutrophils, means trouble fighting infections. So people might get frequent infections or infections that are unusually severe or hard to shake off.
Okay.
And low platelets thrombocytopenia that leads to easy bruising, maybe nosebleeds, bleeding gums, or those little pinprick red spots on the skin, petechiae.
Those sound quite general, though. Any clues that point more specifically to aplastic anemia?
Good point. A detailed family history is key. Any history of blood disorders or bone marrow failure. In kids, we look for specific physical signs suggesting an inherited form, like Fanconi anemia,
Such as?
things like being short for their age, certain skin marks like cafe au lait spots, maybe bone abnormalities. Also, asking about prior jaundice might suggest a post-hepatitis cause.
Ah, okay.
And definitely asking about drug and chemical exposure history is vital. The onset can also vary. Sometimes it hits quite suddenly. Other times it creeps up over weeks or months.
Right, and focusing on the low counts again.
Well, the anemia gives you the pallor, headache, fatigue, sometimes even ankle swelling. The low platelets cause the bleeding, bruising, petechiae, nosebleeds. Infections are a huge risk long-term due to low white cells, but maybe not always the very first thing people notice. And one thing that can be helpful. Usually, in uncomplicated aplastic anemia, you don't find swollen lymph nodes or an enlarged liver or spleen. If those are present, it might point to something else, or maybe a secondary infection.
Gotcha. And specifically in children, how might it present differently?
In kids, the bruising and bleeding from low platelets, purpura, nosebleeds, gum bleeding is often quite prominent. Also, that persistent fatigue, feeling generally unwell, and maybe taking a really long time to recover from bugs they pick up at school because of the anemia and low neutrophils combined.
Okay, so if the symptoms and signs point towards aplastic anemia, what investigations get ordered?
First stop is always the complete blood count, the CBC. That confirms the low counts, the pancytopenia, and tells us how severe it is.
Right.
But the absolute key test is the bone marrow biopsy.
Going into the bone itself.
Yes, a sample of the marrow tissue is taken, usually from the hip bone. That lets us look directly at the cellularity, how many cells are there, and what kind. It's crucial for diagnosis.
And genetic tests.
Often done, yeah, especially in younger patients, or if there's any suspicion of an inherited cause like Fanconi's. Plus, a whole battery of tests to rule out all those differentials we talked about.
What else is involved in that workup?
Well, beyond the CBC and biopsy, you'd look closely at the reticulocyte count. That tells you if the marrow is even trying to make new red cells. A blood film review under the microscope is standard.
Okay.
In kids, maybe check fetal hemoglobin levels. If someone's under 35, you'd likely do peripheral blood cytogenetics to check chromosomes for Fanconi's. Flow cytometry is now used to look for PNH clones. It's replaced the old HAMS test mostly.
Right.
Might check urine for hemosiderin if PNH is suspected. Basic vitamin levels like B12, folate, liver function tests, viral screens, hepatitis, EBV, CMV, maybe autoimmune markers like ANA.
A broad sweep.
Yeah, and imaging like a chest x-ray for infections, maybe an abdominal ultrasound to check the spleen and lymph nodes aren't enlarged. And that bone marrow report will classify the severity moderate, severe, very severe based on specific cell counts and cellularity thresholds.
It's a really thorough process to get the right diagnosis. So once it is confirmed, what's the management plan?
The main goals are, 1, manage the symptoms, the anemia, the bleeding risk, and 2, try to fix the underlying problem in the bone marrow if possible.
How do you manage symptoms?
Primarily with transfusions. Red blood cells for the anemia, platelets if the count is very low or there's bleeding. That's supportive care.
Okay. And fixing the underlying problem.
For acquired aplastic anemia, especially in younger patients, the first-line treatment is often immunosuppression, usually a combination of ATG antithymocyte globulin and cyclosporin.
Suppressing the immune system that might be attacking the marrow.
Exactly. The idea is to calm down that autoimmune attack and let the marrow recover. In older patients, maybe cyclosporin alone. And there's a newer drug, L-trombopag, that stimulates platelet production. It's being used more and more, often alongside immunosuppression.
But wait, suppressing the immune system when white cells are already low? Isn't that risky for infections?
That's a huge consideration, absolutely. Patients are very vulnerable to infection. So meticulous monitoring is key. Prophylactic medications, antibiotics, antifungals, antivirals are often given to prevent infections before they start.
Okay, that makes sense.
Other supportive things include iron chelation therapy if multiple transfusions lead to iron overload. Platelet transfusion triggers are carefully considered for each patient, and using irradiated blood products is important, especially with immunosuppression, to prevent a rare transfusion complication.
What about options beyond drugs?
Well, if there's an identifiable cause, like a specific drug, stopping it is obviously step 1. But the big non-drug therapy is hematopoietic stem cell transplant, a bone marrow transplant.
The cure? Potentially.
It offers the best chance of a cure, yes, especially for younger patients with a matched sibling donor.
What are the chances of a sibling being a match?
About 1 in 4, roughly 25% for each full sibling. If there's no sibling match, an unrelated donor from a registry might be an option, though it carries more risks. And for long-term treatment access, patients often need a central line, like a Hickman or PICC line. So, summarizing the treatments: support with transfusions, immunosuppression to help the marrow recover, and transplantation for a potential cure.
And if it's not treated or doesn't respond?
There's a risk it can evolve into other serious conditions like MDS, leukemia, or PNH over time.
Okay. What about the overall outlook? The prognosis?
It really varies. Some milder, non-severe cases might not even need treatment right away, just monitoring. But severe aplastic anemia historically was very dangerous, with only supportive care, high mortality within a couple of years.
But treatments have improved things.
Dramatically, especially transplant and immunosuppression. Long-term survival is much, much better now than it used to be, though outcomes are generally tougher for older patients or those with very severe disease at diagnosis.
Any way to prevent it?
Mainly by avoiding known triggers where possible possible certain chemicals, unnecessary exposure to some drugs. And reporting suspected drug reactions is important, like through the yellow card scheme in the UK, so we learn more about drug safety.
So prognosis is variable, potential for remission, but might need ongoing care or transplant.
That sums it up well.
And finally, what are the main complications to be aware of?
The big ones stem directly from the low counts and the treatments. So infections and bleeding remain major risks. They're the main causes of serious illness and death.
Right.
Stem cell transplantation, while potentially curative, has its own risks. Graft versus host disease, where the donor cells attack the body, and graft failure.
And the immunosuppression.
That has its own set of potential side effects and increases infection risk too. And then there's that long-term risk of transformation we mentioned, developing MDS, AML, or PNH down the line.
So close monitoring is essential.
Absolutely. Regular checks and managing issues proactively are key to minimizing these complications.
Okay, so pulling it all together. Aplastic anemia, rare, serious bone marrow failure causing pancytopenia. Diagnosis is key. Management has improved hugely, but it's complex, with significant potential complications. This deep dive was really about giving you that clear, high-yield overview for revision.
Hopefully useful.
Definitely. Now, here's something to think about. Given all those potential triggers for the acquired form viruses, drugs, autoimmunity, where do you think future research really needs to focus to make the next big leap in understanding or treating this?
Oh, that's a great question. I think really digging deeper into the exact immune mechanisms, how that autoimmune attack actually works at a cellular level in acquired cases, and also better ways to identify maybe less obvious environmental or drug triggers through large studies.
To get more specific treatments or even prevention.
Exactly. That could lead to more targeted therapies, maybe even ways to prevent some cases. That would be huge.
Absolutely. Well, food for thought, and for all of you revising this and other topics, don't forget passthemsra.com and freenestra.com. Really excellent resources for your exam prep. Thanks for joining us for this deep dive.